All right, well, let's get started today. Welcome to our first in COVID conversation series. Today, we'll be talking about how bad was the pandemic for older adults. We have some fantastic speakers for you today and are looking forward to dialogue and questions as we move through our conversation. So I wanted to do a couple of housekeeping items first. My name is Elizabeth Subcheck. I am the Director of Strategic Alliances at GSA, and I'll tell you a little bit more about what I've been doing with our COVID-19 task force over the past 15 months or so. So we'd like to have you introduce yourself in the chat if you have a moment, your name and organization. This conversation is being recorded and it will be archived on GSA's website. We ask you to keep your audio and video muted until we get to the discussion portion. As you're listening to the speakers, you can keep both of those off, and then we'll turn them on as we get into the discussion portion. You can use the chat box throughout presentations to comment or ask questions. We'll keep an eye on that and bring that forward to our presenters today. You can also flag technical issues in the chat. We have Judy Liu on the line, who's a GSA staff who's going to be helping to resolve those issues. Hopefully we won't have any, but just in case, Judy's here for us. And if you like our format today, please feel free to join us and invite friends to our future conversations. We have a link to those in just a few slides here. So I wanted to give you a little bit of history quickly on our GSA COVID-19 task force. This group was brought together in March of last year to really stay apprised of what was happening with the pandemic as it related to older adults. We have a large number of tools and resources that were created by that group and some of our special interest groups that's on the GSA website. You can go to geron.org/COVID-19 to see all of those. One of the pieces that they put together was a research agenda. And they identified, the task force identified in talking to GSA leaders across special interest groups and sections, 12 areas that they felt like we needed additional research on to understand the pandemic's impact on older adults. We also have a number of articles that were published in GSA Journals, and here are links to a number of special issues and collections that the journals published. Thinking about where GSA wanted to be in the future, we brought together those learnings from the research agenda and the journal articles for this COVID conversation series. Our goal really is to learn from the pandemic, to understand what the implications are for gerontology, and to bring those to you and to hear from you about how the issues have impacted your research, as well as what the pandemic may mean for older adults moving forward. And so we'll hear from a number of speakers in all of our conversations. And then we would like to hear from you about these topic areas and what you're thinking and hearing. So today, as I mentioned, we'll talk about how bad the pandemic was for older adults. Number 2 and 3 are coming in August and September. And so please register for those at the link you see at the bottom of the screen. You can get to that from the geron.org/COVID-19 page as well. And so with that, I'm very pleased to introduce our moderator for these sessions, our curator of content, Stephen Albert. He has been working with us to identify speakers and to put this entire series together. He'll be moderating the conversation today. And so, Steve, I'll turn it over to you. Thank you.
Okay. Thank you, Betsy. Thank you, Elizabeth. It's great to be together with you all. I hope you'll find this useful. We have been inundated with data and information and news and misinformation about COVID over the last year and a half. It might be a good time now to try to pull it together. What have we learned from the COVID pandemic, SARS-CoV-2, and what will the next year look like? What will the new normal look like? We have the great advantage of 85% of people age 65 plus are vaccinated, but the remainder of our society is not. In the US and outside the US, even less so. We have rates as low as 55% in young people, and in certain regions of the US, almost not even a third, or certainly under 40% are vaccinated. So what will the new normal look like as we go forward? Our series starts today with the biggest perspective, the population demography, the long-term care population, and we're going to drill down further in the next months to disparities, mental health effects, system level factors, and ultimately culminate with a plenary or kind of special symposium at the GSA meeting in November in Phoenix. So that's the biggest picture. Let me just give you a few minutes of background. Not that this is so new to anybody, but just so we're all on the same page. You know, we have over 4 million deaths from COVID worldwide, and probably 200 million infections at least worldwide. In the US, we have probably about 34 million cases known, but that's almost certainly a vast underestimate. Some reports suggest that about 10% of the population we know is infected, and it may be even higher than that. We've had 609,000 deaths in the US, a really tragic increase in excess death, which will lower our life expectancy estimates for the next period. And we're still figuring out how to live with this thing. It wasn't so long ago that we reached our mode of deaths of over 4,000 deaths in a day, but now we're down to really only a handful of that, really quite a reduction. And that has a lot to do with vaccination and the social distancing measures we put in place and masking mandates and all kinds of things. Recent reports have come out from the Commonwealth Fund, for example, that we really escaped a spring surge, which would have perhaps produced another 300,000 deaths had we not had access to vaccinations. So we are not, I would say, out of the woods yet, but perhaps we can see what the future might look like. How will we live with COVID going forward? And then we have our special populations, long-term care in particular. The Kaiser Family Foundation continues to put out some excellent reports there. And that population took a terrible, terrible hit. Something like 1/3 of all the deaths from COVID were in long-term care. And in my state, Pennsylvania, we had 2/3 of those, 2/3 of the COVID deaths were in long-term care. So that's where we are. That's the biggest picture. And I'm very, very pleased that we have two experts with us today to help us sort through a little bit of this. I myself am not really an infectious disease modeler, but I don't think anybody in public health or gerontology could ignore COVID. And I found myself, I don't know about you, in the last year and a half or so, spending probably 1 to 2 hours a day just trying to keep up with the fire hose of information and data. Many of us were recruited to become talking heads for media. They were looking for somebody to talk about aging and COVID, and even the people in the B list like myself were tapped quite often, and we had to become experts in a field that we were never really trained for. So it has been, I think, an interesting time and an interesting challenge. So I am coming from the University of Pittsburgh. I'm in the Department of Behavioral and Community Health Sciences with a focus on aging research, and in a good position, I think, to think about some of the public health implications of COVID. We have two great guests with us who are actively researching this area. Elizabeth White is an assistant professor in the Department of Health Services, Policy and Practice, and at the Center for Gerontology and Healthcare Research at Brown University School of Public Health. Great to have you with us, Betsy. Just another word or two. She's a geriatric nurse practitioner, extensive clinical experience in long-term care. And she and her colleagues at Brown have teamed up with the Genesis healthcare system, a very large long-term care network, and doing some terrific research on really population scale focus. Many publications. You might recognize her name and her team. From the New England Journal of Medicine to JAGS, active in gerontology, looking at facility level predictors of outbreak and asymptomatic infection rates, resident level predictors of mortality, trends in mortality, even some antibody studies and vaccine effectiveness and safety studies. Lots of interesting things. There is also something called the Impact Collaboratory on COVID-19, which has added additional nursing homes in addition to the Genesis system. So they're really tracking about 1,000 nursing homes. Terrific resource, and Betsy will talk a bit more about that. I'm also with Andy Sharma, University of Maryland. We wanted to cover not just long-term care, but the broader demographics of COVID and some simulation studies of the total impact of COVID on aging in the United States. So terrific that we've got Andy with us. Did I say University of Maryland? I'm sorry, I see Northwestern. Andy, could you clarify that? We have this right?
Sure, thank you. I was formerly a research assistant professor at Maryland College Park, now I'm at Northwestern. Thank you.
Okay, thanks for that clarification. Sometimes the websites are a little bit behind the times when I did a little Googling before. Okay, all right, so let's begin with Andy then. You have about 7 minutes in our conversation here to give us a little thumbnail on where your research has taken you and where you think you're going next.
Well, sure. Thank you. Let me begin by thanking GSA for hosting this series of seminars, Dr. Albert for coordinating, and also my co-presenter, Dr. White. I'm thankful to be here, particularly during this challenging time. The impetus behind my research primarily occurred, much like Dr. Albert mentioned, reading so much research and volumes of information and not being able to delineate how much of it was accurate and how much of it applied to the general population. To expound, most of us who had become accompanied with COVID and became aware of it, a lot of these research reports were coming from China. And initially, most of the information we acquired was the mortality risk profile for individuals in particular provinces in China. And then later that research extended to New York. And what was saddening for me is not only to see the high rates of mortality for older adults, but much of this was coming from clinical reports and hospital reports. So I was interested in better understanding what was the mortality profile for the general population of older adults in the US. And much like Dr. Albert mentioned, after spending voluminous time researching, I really couldn't find anything that gave us some indication of what this meant for older adults in the general population. So utilizing current data at that time with the risk of mortality for older adults, and particularly those who have hypertension, cardiovascular disease, diabetes, and obesity, I conducted a simulation using the National Health Interview Survey. And what I uncovered was the risk profile was roughly 3 to 5% for older adults that were near the age bracket of 65, but increased monotonically after 65 and was quite dramatic for individuals 85 and over. And the disparity between those who had a general population characteristics versus those who were obese or had hypertension or cardiovascular disease was also significant and higher. So I became interested in learning more about COVID and what policies we could engineer for older adults. And one of the things I realized, and the article in JGSS was published September of 2020 online, so almost 8 to 9 months ago. And in that article, I put forward and emphasized the importance of misinformation and the importance of public policymakers and the gerontology community working together to alleviate some of that misinformation and reestablishing public trust. And I was pleased to hear Dr. Murthy at the CDC very recently talk about the emphasis of misinformation, particularly with social media and Facebook. So I was pleased to hear that. I wish that had come earlier with the administration, as early as maybe October of 2020, shortly after my article was published. Now, continuing with that objective of misinformation, I'm saddened to see that this continues to perpetuate it and that individuals have continued to have limited understanding of the risk of mortality from COVID, particularly at older age brackets. And what we know is individuals that are 65 and over, some suffer from isolation, limited family contact, poverty, health disparities. And in addition, many may not be savvy in navigating the internet for proper information. So my current research trajectory examines how older adults are engaging with this type of miscommunication and what resources are they seeking to identify good sources from bad sources, reliable sources from non-scientific sources, and what can we as local community leaders in the gerontology field can do to alleviate this misinformation, but also how public policymakers can use this information to really package what I would call a national message on health communication. Presently, as far as I know, we don't have anything formal. And this is a great opportunity for us as a nation to develop a national plan for health communication, particularly with respect to older adults.
Great, thank you very much, Andy. Elizabeth, Betsy, you want to say something about your work?
Sure. Thanks for inviting me. Happy to be part of the panel today. So I'm on faculty in the Center for Gerontology at Brown University in the School of Public Health. You know, for anyone who's not familiar with the kind of work that we do here, we're kind of a large data shop. We have a lot of different types of research that we do here, but one of the main things that we do is secondary data analysis of large administrative data sets, claims data. We have, you know, within our center, we house Medicare claims, the minimum data set, OASIS, you know, Medicaid data, you know, a whole range of administrative and claims data that goes back for many years. And, you know, typically when we're doing research on data, you know, even our most current data is usually about a year or 2 years old. When COVID hit, and, you know, the initial epicenter of the US COVID pandemic was a nursing home in Kirkland, Washington, it became very obvious that we had to think very differently about how we conduct research, because using data that's a year or 2 years old doesn't help you in the middle of a public health crisis. So I work with Vincent Moore. He's the PI on most of our COVID work here at Brown. So what Vince really took the leadership on was recognizing that we needed real-time clinical data to be able to understand what was happening in the nursing homes. And if you can think back to, you know, back in March and February, March, April, we really didn't have good data reporting, even just on the number of cases and deaths within nursing homes. It wasn't until the end of May that the federal government started requiring that nursing homes report into the National Healthcare Safety Network system, which many people are now using for research. But in the earlier months, you know, the states were collecting various amounts of data. Some were releasing it publicly, some were not. You know, it was a real patchwork of data. So we entered into this collaboration with Genesis Healthcare, which is one of the largest long-term care providers in the country there. And what we've been doing since March of 2020 is they've been sending us all of their electronic health record data. We get nightly data dumps from them. And then they also send us other, you know, clinically relevant data on testing, data on vaccinations, both of the staff and the residents. And, you know, this has been a very real-time collaborative effort. We, throughout the pandemic, have been meeting weekly with the clinical leadership at Genesis to help interpret the data and also just to make sure we were asking the right questions and, you know, reading the data correctly. So, you know, with these data over the last 15 months, we've answered a number of questions related to on a whole host of things, everything from facility level predictors of outbreaks, and sort of the consistent story there is that, you know, even high quality nursing homes, when they're in a high risk area, a county that has very high virus prevalence, are, you know, at high risk of having severe outbreaks. So we looked at facility level predictors. We looked at predictors of 30-day mortality, specifically within the nursing home population, as work from Dr. Sharma and others have shown, age and comorbidities are very strong predictors of mortality from COVID. But unfortunately, that's pretty much the nursing home population. So, in terms of prognosticating within the nursing home population specifically, we also found that cognitive impairment and functional impairment were almost as strong predictors as age for predicting who would not survive from COVID within the nursing home residents. We looked at longitudinal trends in mortality over time, and we found that even prior to vaccinations, that we did see case fatality drop within nursing homes, suggesting that there was some learning in how to manage this virus within the long-term care environment, through cohorting and infection control practices and testing protocols and a number of other interventions. So we did see, mortality rates had started to drop over time even before we saw the vaccines. But then certainly when the vaccines came out, that we kind of shifted, and that became the main priority of our research. We had a research letter in the New England Journal that looked at vaccine effectiveness and looked at breakthrough cases in nursing home residents. And, we saw even in this frail, vulnerable population that tends to have lower responses to vaccines were still highly effective in reducing incident infections. And the breakthrough cases that we did see were mostly asymptomatic. So the vaccines have just been absolutely life-saving within this population. We also have work that's been led by Barbara Bardenheier, who's another faculty here at Brown, focused on vaccine safety. So she's been running an adverse event monitoring study in conjunction with the CDC. That paper came out recently. We didn't see any major adverse effects within the nursing home population that hadn't been identified within the general population. So we've had kind of a range of work. We're now building on the work within Genesis under the Impact Collaboratory, which is a multi-institutional NIA-funded project. We now are receiving electronic health record data from, as Dr. Alpert mentioned, about 1,000 nursing homes that all use the same EHR vendor, Point Click Care, which is a common nursing home EHR vendor. And we're continuing to build on that further. We also have relationships with 5 other nursing home EHR vendors, and we're looking to build a data repository, an EHR data repository for roughly 10,000 nursing homes across the entire country. So I think the main lesson that we learned here is that with COVID, we had to think very differently about how we were conducting research, the pace at which we were conducting research. With COVID, you can ask, the questions that you're thinking about 1 month, 3 months down the road, they're not relevant anymore. So, we've had to just work at a much more rapid pace. We've had to work very collaboratively with our clinical partners at Genesis. And it's really been a rewarding experience. So we also have work that's a more pragmatic nature under the Impact Collaboratory that I haven't been leading. That's been led by Vince and Sarah Berry at Hebrew Senior Life, which has been focused around vaccine acceptance for residents and staff. And that involves surveys and focus groups of staff to try to understand mechanisms around vaccine hesitancy. And that also involved a pragmatic trial to help boost vaccine confidence among nursing home staff. So we've had a very wide portfolio. I'm happy to talk about any of our individual projects or just kind of the data itself. I did not anticipate, March of 2020 that I would be a COVID researcher, 15 months later, but here I am. So it's been quite a whirlwind, and looking forward to the conversation.
Terrific. We have excellent expertise. I'm so glad you two could join us today. And I see we have a lot of activity on the chat. Lots of people have their favorite websites for data and opportunities for publishing. So this is a terrific chance for us just to share notes and update each other on where we're going with this thing. Andy, let me start with you. Your study was a simulation study, and the association between age and mortality was frightening. You got up to, even on a the most gentle scenario, still had 40% mortality risk for people over age 80 in the absence of vaccine, I assume. Now the situation is completely different. would you say older people can relax now to some extent or not really?
Thank you. That's a great question. And that's correct. That would be in the absence of the vaccine. The paper was initially started in March of 2020 and was published in September of 2020 prior to widespread vaccination use. So that is correct. In terms of my views on the mortality profile today versus 6 to 8 months ago, I would like to delineate that into two time periods, one the short term and two the long term. To clarify, I think today the short-term mortality has decreased, and I believe that's for really three reasons. One is the most vulnerable individuals have already succumbed to the COVID pandemic, unfortunately and sadly. And so we have lost that group out of our life course table, if I can use that term. The other aspect of why I think the short-term mortality profile has decreased is because I think we have stronger immunity and greater immunity among the general population. Initially, there were some concerns that the antibodies would dissipate or slowly dissolve and not be part of the blood system within 3 to 5 months. I think more current research indicates that that may not be the case and that it is continuing to be produced in the bone marrow. And the initial study did not examine the bone marrow. So I think we have greater immunity. Certainly, what that means for the Delta variant is a different story. And I also think, as you pointed out, the vaccination rates have increased and become more widespread, particularly among older adults. And that seems to provide some strong support against new variants. The Delta variant is still unknown at this point, but the previous variants, particularly the UK, the South Africa variant, we seem to find evidence that the vaccination or the deployment of the vaccine is still effective to a large degree. However, I think the mortality profile for the longer time horizon is unfortunately still high. And the reason I state that is that more and more research is uncovering the long-term impact of this virus. And what we're slowly noticing is that there are some debilitating consequences of having this. Individuals who have suffered from this virus 8, 9, 10 months ago, sometimes even more than a year ago, continue to experience the ill effects of difficulty with breathing, chest discomfort, chest pain, loss of memory, lack of cognition. So I think what we will see is in the short term, a continued decreased mortality profile for older adults, particularly 65 and over. However, and unfortunately, I think the mortality profile will increase for those that are in the older age brackets in a longer time horizon. And as I think you astutely pointed out, a decrease in life expectancy because of that. What remains to be seen is how this virus impacts individuals 5 to 10 years down the road. And very quickly, when I was conducting research on COVID as early as almost a year ago, we had limited data, limited understanding. And one of the aspects I undertook was to try to understand this coronavirus because it initially, and to some degree, there is a respiratory ailment and a respiratory condition behind this. So I looked at SARS. And when I was researching SARS to try to understand COVID-19, what the research indicated is individuals who were afflicted with SARS passed away or experienced mortality potentially 2 to 3 years earlier than they would have if they had not had contacted SARS. So I think what remains to be seen is with the COVID-19, what will occur down the road for individuals? Will we continue to see a decrease in life expectancy, and how much of that decrease will exist? And I think what's also unfortunate is if these individuals do at some point end up in long-term care, the cost will be exorbitant. So I think from a policymaker viewpoint, the economic cost of individuals having this condition and the long-term debilitating effects will be costly not only for the individual, but for the nation and for families, because they may incur higher costs being taken care of in long-term care facilities.
You know, Andy, I think your study didn't account for geographic variation regionally. And we have some states like Mississippi, Arkansas, Tennessee, with very low uptake of vaccine, 35% or something like that. If you were going to redo your study, could you take that into account, and would those states look like your initial projections, or what do you think?
That's a great question. And unfortunately, we're seeing places like Arkansas and some of the states in the Southeast US experience higher mortality, particularly among age brackets 70 and older. And although my study did not at that initial outset take geographic location into account, I think what we would see is certainly a clear delineation between the northeast portion of the US versus the southeast. And I would estimate that the southeast will see higher mortality rates, particularly in the older age brackets, because of the vaccination that you had mentioned. But also, I think what's important is not just the vaccination, but the lack of access to healthcare resources. Poverty has been found to be a strong indicator of mortality, strong association, economically depressed areas. And I also think what's important is the individual behaviors at the health level. And some older adults, unfortunately, still have concerns about the vaccination. They're concerned about its safety and efficacy. And I think that may be more widespread in certain geographic areas. So I agree with you, and I think that's a good point. Future studies should account for the geographic variability that exists with not only vaccination, but perceptions surrounding COVID and their personal preferences in vaccination. And I think that could continue to be a robust research area for upcoming scholars who are interested in better understanding how we can devise policies. And I think the policies do need to be different based on geographic location. We know cases like Florida, there are instances when throughout most of the pandemic, individuals were not required to wear masks. Stay-in-place orders were rather loose. And there wasn't a fundamental strong underpinning in terms of a strong health communication message by state leaders initially at the outset. So I think some of these states can work very closely with gerontologists to devise particular messages. And one last point I would like to emphasize is when we're looking at health conditions, there's certainly geographic clustering. We realize obesity is predominantly more impactful in the Southeast than perhaps the Northeast. We see cardiovascular diseases among certain populations more so than others. And I think what we need to do, and I think the burden is really upon us as gerontology experts and scholars, is to help work with policymakers to devise crafted measures. I think the Southeast and the states you pointed out, Arkansas, Alabama, Florida, Georgia, et cetera, I think the policy message needs to be crafted differently for older adults than it is in the Northeast, because as we mentioned, the personal preferences, the beliefs around vaccination, and also the geographic disparities that exist in how we can reach these targeted individuals in a more effective manner. So I think geography, to summarize, is an important element, and I encourage attendees, I've noticed a number of them are GSA pre-doctoral students or interns, to take your advice at heart and continue to pioneer the forefront in gerontology research by examining microgeographies and micro scales, whereas mine looked more at the national analysis level.
Right. You know, that's an excellent point. I remember at the beginning of the pandemic, the Dartmouth Health Atlas put together a state-by-state profile of the proportion of people age 65 plus with 2 or more comorbidities, because that was considered a risk factor for poor outcomes with COVID. And so even the variation was impressive, just as you say, from the Southeast to the Northeast, for example. And so even apart from vaccination uptake, there probably were different risk profiles by geographic area. And that's something for us to think about. So I'll come back to you, Andy. Let me switch to Elizabeth for a second, if I may, to just talk a little bit about the long-term care population and a similar kind of question. So Elizabeth, I'm thinking of the JAGS paper. It got a lot of media. So congratulations on that. And you found that for every 1% increase in the county prevalence, that's you saw the incidence of an outbreak in nursing homes increased by about 1/3. So this was any cases in a long-term care facility. So even the most impressive infection control in a nursing home would still be overshadowed or defeated perhaps by a high transmission locality, right? Do you think with vaccination, we've more or less obviated that? If truly 85 to 95% of people in a nursing home were vaccinated, can they relax their guard a little bit about community transmission if they're in one of these regions of the country?
So the short answer, I mean, yes, a large proportion of nursing home residents have been vaccinated. We do see much lower vaccination rates among staff. You know, I think what COVID has really taught us is that when we're thinking about how to protect nursing home residents, we have to think about it from a population perspective. So, you know, the initial study that we had, we used data, I think it was through like mid-April or end of April. And there's been something in the order of about 30 studies since then that have used various data sources, either from states, from the CDC, CMS, the National Healthcare Safety Network data, and far and away, the strongest predictor of outbreak of case fatality within nursing homes is the burden of COVID within the community where the nursing home is located. Because nursing homes aren't bubbles. I mean, even though the nursing homes were shut down to, you know, so-called visitors, which we could have a whole discussion around that, whether or not, you know, family members or visitors or essential caregivers, which I would argue the latter. But even still, I mean, you have staff coming and going, you have vendors coming and going. You know, nursing homes are living, breathing entities within communities, and they have interaction. So when, you know, COVID is in the community, it gets into the nursing home. And, you know, across this body of literature that's been produced, you know, the more typical structural characteristics that we like to look at, you know, the payer mix, for-profits, the staffing, the 5-star ratings, you know, these things have had much more inconsistent stories where you look at, you know, their ability to predict which nursing homes do better or don't do better. And that's important to have that perspective, because if, you know, you take you know, there were a couple of studies that did show, you know, a correlation between higher star ratings, you know, doing better during COVID. And a lot of that is sort of methodologically how you know, conduct the analysis. And there have been, you know, some flaws in some studies that are out there. But, you know, it affects the narrative. So if you think that it's the higher quality nursing home, if it's the worst quality nursing homes that are having the worst outbreaks, well, you know, then the policy response is to go after the nursing home and to penalize the nursing home when they have worse outbreaks. But the problem with that, and CMS actually did take that sort of an initiative. They had kind of a value-based payment incentive program where, you know, the facilities that were having worse outbreaks were penalized financially. They also had additional surveys that came in, which is administrative time, administrative burden. And, you know, I think we're still learning about, you know, how effective those surveys have been and whether or not they actually, you know, found the things that mattered and, you know, protected residents. So, you know, if you take the narrative that, you know, primarily the nursing home factors that are influencing the you know, what happens within the facility, then you go after the nursing homes. But if you take a broader lens and you understand, you know, even high quality nursing homes in really high risk areas are going to be severely affected, then you need to really look more at public health measures around vaccination, around testing, around masking, and all these other resources around getting PPE supply, which was a huge problem in the initial months of the pandemic, getting PPE into nursing homes. So, you know, it's really important how you analyze the data because it affects the narrative that you tell and then what the policy response is.
Very good. Good reminder. You know, one of the things in your paper that impressed me was for each additional 10 beds in the size of a long-term care facility, you had a strong association with an outbreak. Do you think that maybe we should have a new star in the 5-star rating for size of nursing homes, that smaller is better when it comes to our pandemic age, which we may be entering now?
Yeah, it's interesting. That has been another, when you look at structural characteristics of nursing homes predicting outbreaks, bed size has been another significant predictor. So across the literature, so larger facilities tend to have worse outbreaks, and that tends to speak to, you know, the number of, you know, larger facilities have more staff, more people coming and going from the community. And there has also been a few studies that have looked at smaller facilities, looking at like the greenhouse model. This was not our work, but other people have done that and have shown that they did do better. There was work recently from Brian McGarry and David Grabowski. It just came out, I think it was in Health Affairs just last week. where they actually looked at controlling for staff levels and controlling for bed size. They found that a strong predictor of outbreak was the number of unique staff members that were coming into the building. So it's not just your total staff size, it's also what proportion of that staff are agency staff. What's your turnover rates? You know, if you have, you know, a 100-bed facility that, you know, has pretty good staffing and, you know, mostly full-time, you know, employed staff, are going to have fewer people coming in and out of the door and potentially bringing the virus into the building versus, you know, a 100-bed facility that, you know, half their staff is agency and, you know, they have, you know, 400% turnover of their CNAs and it's just a constant new mix of people. So, you know, there's large body of evidence prior to COVID, higher staff turnover, you know, poorer retention. These are closely linked to nursing home quality. And I think that this really highlights the need to, you know, the nursing home workforce has really gone through it in, you know, during the pandemic. There's been, you know, about 100 or almost 2,000 deaths among nursing home staff. And, you know, this was a vulnerable workforce to begin with, high rates of turnover, you know, CNAs in particularly not paid well, oftentimes don't have health care insurance. And, you know, I think as we're thinking about long-term care and the future of long-term care and what that looks like, we really need to think about the workforce, really need to think about investing in the workforce and, you know, how we pay for these things. So.
Let me put you on the spot for a second. You know, so imagine a nursing home that did everything right. Okay, not a lot of agency staff. You know, proper organizational communication, which you talked about in a different paper. Appropriate PPE, maybe appropriate enforcement of vaccination by staff as well. Do you think it could offset the the risk from community transmission? How much can we really expect in the, you know, the best scenario of nursing home response in a state or in an area with high local transmission? Could they, you know, get outside of that risk? What do you think?
Yeah, and it's hard. So in terms of measuring actual infection control interventions, so if you're trying to, you know, identify, you know, cohorting strategies or testing protocols, those are really hard things to measure and do it in a systematic way, you know, across multiple different providers. Like, for example, we know within Genesis, they have like a risk stratified approach to testing, visitation, within their facilities. So they basically risk stratify all their facilities every week based on community prevalence, community vaccination rates, and whether or not the facility has had any new cases in the prior 14 days. And then that guides how frequently they test their staff and how frequently they test their residents. So it's a constantly, you know, evolving protocol. But that is, you know, even just within Genesis, which is a, you know, one organization, kind of testing how that gets applied across, you know, hundreds of nursing homes is really challenging. You know, the easier things to measure, like staffing and, you know, what have you, you know, there's been work done around that. I will say about vaccination rates. So we had in our vaccine effectiveness paper, we did look at the relationship between breakthrough cases and community prevalence and staff vaccination rates. And what we generally found was that in higher risk communities, you did see slightly lower breakthrough infections among facilities that had higher staff vaccination rates in people who were partially immunized or not vaccinated, the unvaccinated. So there did seem to be a protective effect for having more staff vaccinated in the highest risk areas for people who were not fully immunized. But then when you looked in lower risk areas, it was kind of a mixed bag. And when you looked at the fully vaccinated population, you didn't really see a relationship between staff vaccinations and resident vaccinations, just because the vaccines themselves are so highly effective. So it's something we're still exploring. And kind of to the earlier point too about, you know, thinking about moving forward and the variants in particular, one of the areas where our research is shifting now is looking at durability of vaccine-induced immunity. So one of our colleagues, Stefan Grabenstein and David Canaday, who's at Case Western, the two of them, they did an antibody study where they followed people for 6 months, nursing home staff and residents for 6 months. And their paper came out, I forget where it was published, but they showed that nursing home residents definitely have lower antibody titers versus the staff. So again, this is a high risk population that doesn't respond as well to vaccines as your general population. So we're kind of building on that now. We actually just put a proposal in where we're going to be trying to follow this now over the next 2 years, and doing lab draws on people every 6 months to try to understand durability of immunity in this population, if they need to be boosted, and if so, when. So this is kind of where we're shifting now.
Great research, great questions. Let me throw one other thing out to you. We're in a different era now with vaccination, and of course, the Delta variant and any emerging variants may change that picture. But do you think it's a compelling argument for younger people to be vaccinated to help protect older adults? And this is an ethical issue that we're going to come back to in a later one of our conversations, but you guys have seen the great mortality impact of COVID. What is your impression? Is that a reasonable strategy to encourage younger people to be vaccinated to help protect older people? And maybe this would be outside the long-term care setting where we might still be more of an issue. Do you have any thoughts about that?
Andy, do you want to offer first?
Sure, thank you. I think that's a great question. And I think, as you pointed out, ethically, we have an obligation to try to combat this virus on multiple fronts and try to get some semblance of a normal life and allow individuals at all age brackets to have a healthy, meaningful life. And unfortunately, this pandemic has torn that apart. I know my niece was going to graduate from high school, and it was the midst of the pandemic. And she did not have a high school graduation like many individuals. She's a first-year student now at Penn State, and some of her classes were online, some were not. And so she's missed out on that first-year experience. So I think young adults can do much to help older adults and help the general population overall to get back into some semblance of normalcy, and also try to lead a fruitful and meaningful lives. I think what's also important to note is these are the summer months, and some of us, or many of us, are on vacation or planning vacations, whether regionally or to see family and friends that we may not have seen in a very long time. And that includes grandparents. And grandparents visit their grandchildren, they spend time with their family. And I think when grandchildren, particularly of certain ages, go to summer camp, and there have been a few reports of this already, of individuals going to summer camps. And even though they have had the vaccine, they've been tested positive. And we've had outbreaks in some of these summer camps. Unless there's testing, unless there's verification, that those individuals can very well go back to their homes and to visiting their grandparents and bring about a different strain. So I think recognizing that these are the summer months, these are peak months for families and communities spend time outdoors, particularly as we just had recently had July 4th celebrations, and as we will with Labor Day and other festivities that really bring community back into a social environment and atmosphere, that all adults, young adults and older adults, take their part in their initiative. And one thing, if I can please suggest, is in addition to vaccination, there are other activities or proclivities an individual can undertake aside from their personal preferences, which is to practice safe distancing and social distancing, wearing masks in areas that have heavy traffic like airports and airplanes, train stations, bus stations. If you're aware that you may be in an area that may have a predisposition where this virus can spread quickly, washing hands thoroughly. So I think in addition to vaccination, and as I mentioned at the outset, I think what we really need is a strong, united national message for the public interest in terms of communication. And I think we did that very well initially with hand washing, mask wearing, and social distancing. Businesses did that, organizations did that, public enterprises undertook that. And I think, as you mentioned at the outset, when we had our short conversation before the start of this talk, is the fatigue that has set in. And I think we need to continue to remind people in a gentle manner of some of the initiatives that they can undertake. So absolutely, I agree. I think young adults can take a more active role in promoting the well-being, but also their well-being. I don't think they want to continue to have a second year of college that is online. I think they also want to visit their grandparents. I think they also want to take summer vacations with their family and friends. So I think the incentive should be all the positive things that can occur with trying to get control of this. And as I mentioned, this not only includes vaccinations and increased rates of vaccination, but also personal responsibility.
Okay, good. Betsy, you want to weigh in on this?
Yeah, I mean, it would be great if we had like a public health messaging around, getting vaccinated so you could go visit grandma. But, and it's kind of, when you look at it from the flip side, I mean, the impetus behind so many older adults getting vaccinated was so they could go see their grandchildren, hold the grandchildren. And, particularly, I mean, we're just beginning to understand the effects of loneliness and depression and all the mental health, effects of COVID on older adults. So, unfortunately, we do still see lower, I mean, at least in the work we've done, like when you look at the staff, you still see that the younger staff are much less likely to be vaccinated than older staff. And that's, risk perception and, being young, thinking you're invincible. But, we're still learning about long haul COVID. We know that it could have some pretty significant effects even on, younger adults. And, I think it still remains to be seen what the long-term consequences of this are for, people in their 20s, 30s, 40s. So,
Betsy, are you seeing any pressure on nursing homes to require COVID vaccination in staff the way we're seeing in certain hospitals now?
Yeah, it's definitely become more of a more vocal conversation, I would say, in the last month or two, where there's starting to be more discussions around mandating vaccination for healthcare workers, particularly in long-term care. I think when the EUA first came out, there was a lot of hesitancy around, mandating something that was under emergency use authorization, just for the, moral, ethical reasons. And, in our work under the Impact Laboratory, our pragmatic work that involved, the focus groups and the surveys of staff and families and residents, trying to understand where the areas of concern were. I mean, the strongest, themes that kept coming up were people that just, were concerned there wasn't enough data, the vaccines were still too new, that, all these things that, have been shown in other populations. So, mandating a vaccine when it's only a couple of months past emergency use authorization, that is a much harder thing to do. Now, millions and millions of people have been vaccinated. There's a little stronger footing to do that. And we have, extensive safety profiles on these vaccines. So it is definitely becoming more of a conversation now. And I think you're probably going to be seeing it becoming a more prominent conversation in higher risk areas of the country where they see lower vaccination rates. So, but on the flip side of that, you have to be very careful and, thinking about staffing, if you're going to be requiring staff to get vaccinated, are they then going to be, leaving their jobs? So it's a complex discussion. It requires a lot of buy-in. This is not something that should be like a top-down management decision. It really needs buy-in from employees, from staff, from the unions, and, understanding how to make people feel comfortable around these.
Okay, great. Good thoughts. Okay, we're now in our last 5 or 6 minutes. We're getting a little activity on the chat. Maybe we'll throw it open to the audience a bit. Great comments from some colleagues at Rutgers and some other places. I wonder if the Rutgers folks, I guess you're doing some work on how community organizations can support older adults. Do you want to say a word about your research? Maybe we can unmute you and you can join the conversation.
Oh, sure. Thank you. My name's Althea Pasten Stevens. I'm a postdoc at Rutgers School of Social Work. I was responding to your prompt asking if there was other topics that we would be interested in also discussing that needed further research. And I was looking at the 12 items that was posted earlier in the session that GSA had identified as areas for research. And I, was wondering, I thought maybe there was a little corner where ours might fit in there, but maybe there were other people that are also doing some similar work too that we might be able to connect on in that area. I work with Dr. Emily Greenfield, and we research age-friendly community initiatives in Northern New Jersey right now. And we've just been seeing so many anecdotal accounts of ways in which community leaders and organizations have been contributing to their communities in response to social needs during COVID. And we wanted to be able to enhance that to more empirical evidence as well, on top of just the anecdotal. And so any opportunity to connect with other folks that are doing that too would be great. But also thank you to the presenters today. It was really great to hear about the work that you're doing as well, because I'm usually focused in kind of the social world too. And so it's good to hear about the work that's being done at kind of the crossroads there with also the health and medical pieces too. So thank you.
I'm just curious, Althea, is your group looking at all on how to get vaccination to older people who can't leave their homes easily because of disability or things of that sort, and who may have an array of home care workers coming in and the risk of infection that way?
So an example of something that we might include as a finding in our study on that would be a community who noticed that there were older adults who were having trouble finding ways to get to their vaccination appointments. And so they then found a local nonprofit organization that had a van that was just sitting around not being used because everyone was social distancing, and they were able to work with that organization to get that van to go and pick up older adults and take them to their vaccine appointments.
Okay.
Another example could be an organization that realized that this senior housing location had a lot of people who would have a hard time getting to appointments, and they were able to arrange for a vaccine clinic to be brought into that location.
Great, good moves. We have a few other thoughts here. One is a campaign to get vaccinated for grandma probably won't be able to overcome people's concerns about vaccine safety. Well, what is the answer to that, friends? Because we should all think about this issue. It's a very big challenge, I think. Betsy, were you going to say something?
Yeah, I mean, and just to kind of piggyback onto what Althea was saying, leveraging your trusted community organizations, leaders within the community, faith leaders, local primary care providers, whoever it is that people trust. It's kind of at this point, the people who want to be vaccinated have been vaccinated, and now it needs to be this very grassroots effort at, having the difficult discussions with the people who are still hesitant or, for a myriad of reasons. And so very important to just be thinking locally about how to reach these people.
We have another comment that until we take care of the work climate of the nursing home, or the where we have low pay and high costs, maybe the answer is a lot of reorganization of the long-term care facilities might be a good public health move, just to address the needs of the staff there.
Yeah, I mean, the one thing I would say is I think that, I don't know if I would call it a silver lining or not, but one thing that COVID has done, it has just laid bare the systemic underinvestment in long-term care in this country. I mean, we have a long-term care system that is predominantly paid for by Medicaid. 6 out of 10 nursing home residents are paid for by Medicaid. Medicaid pays less than the cost of care. So until we, systemically rethink how we pay for long-term care in this country, we're going to be dealing with all these problems and underpaid staff who are doing yeoman's work, heroic work, who unfortunately have gotten a fair share of blame during the pandemic. But until we just really think about how we invest in long-term care in this country, these are just going to be continued problems. And in the infrastructure bill, they had thrown long-term care in there, and we were all kind of and then they took it out. So still working on it.
Okay, well, it is approaching 1 o'clock. We have a question here that I think maybe GSA should think about, and that is, what will we be doing about vaccination clinic or testing at the GSA meeting? I think that's an open question. The world could look very different for 3 or 4 months from now, but something maybe to think about. And I would just like to thank our two interlocutors, Betsy White and Andy Sharma. Terrific insights on where we've been, helping us think about where we're going with this whole thing. I'd like to thank our participants. Excellent, excellent resources in the chat. I hope we can share that. And also, I'd like to thank the GSA staff, Judy Liu and Elizabeth Sobchak and Karen Tracy and others who really put this together. You don't know, there's a lot of work behind an effective webinar, from the planning and technical side all the way to the publicity. And it's been my pleasure hosting it. Come back a month from now and you'll get to hear more about COVID and aging, and our next focus will be disparities. So I'd like to thank everybody. We're going to sign off here now, and I hope this was profitable. A recording will be available, and stay tuned. We're going to try to roll this all together in our November GSA in-person meeting. Thank you all. Thanks again.
Thank you. Thank you.
Okay. Bye, everyone.